Okay, so imagine waking up and you suddenly can't extend your left wrist, like at all.
Right, you'd probably just assume you slept on it weirdly.
Exactly. You brush it off as a compressed nerve from sleeping poorly, but then, say, a month later, you develop this really profound foot drop on your right side.
Which is terrifying, obviously.
Yeah, completely. And on the surface, these seem like two totally isolated mechanical injuries.
Yeah.
But the twist here, and this is wild, is that the actual culprit driving the destruction of your peripheral nerves is the adult onset asthma you were diagnosed with 2 years prior.
Yeah, that is a huge twist.
Right. Welcome to the deep dive. Today, we are exploring this incredibly detailed medical review by Dr. Jennifer A. Tracy. It's called Autoimmune Axonal Neuropathies, and it was published in the Continuum Journal on Peripheral Nerve and Motor Neuron Disorders.
It's a fantastic paper.
Yeah.
Really comprehensive.
It really is. And our mission today is to figure out what happens when your body's immune system mistakenly attacks the actual wiring of your nervous system.
Specifically the axons, yeah.
Yeah, right. So, okay, let's unpack this with a quick analogy. If our nervous system is like a house's electrical grid, this deep dive isn't about the insulation wearing off.
Right. We're not talking about demyelination here.
Exactly, not the insulation. We are talking about the actual copper wires, the axons, being targeted and destroyed by friendly fire.
And, spotting these specific autoimmune axonal neuropathies is, it's not just some academic exercise. It's crucial for you as the listener to understand this because these conditions are immune-mediated.
Meaning we can actually do something about them.
Exactly. They are potentially reversible or at least stabilizable with the right immunotherapy. But, and this is a big but, only if the complex underlying cause is correctly identified.
Which brings us to the rogue immune system. Let's start with maybe the most direct physical attack on these nerves, which is basically choking off their blood supply.
Right, vasculitic neuropathy.
Yeah, vasculitic neuropathy. So taking our copper wire analogy, this is where the immune system attacks the blood vessels feeding the wires, right? The vasa nervum.
That's spot on. The inflammatory cells invade those microscopic blood vessels. You get fibrinoid necrosis, the vessel wall gets destroyed, and basically the downstream axon just starves to death.
Wow. And the source mentions this presents with an acute to subacute onset and prominent neuropathic pain.
Oh, incredibly painful. And the classic presentation is something called mononeuritis multiplex.
Right, the patchy power outages.
Exactly. Because the attack on the blood vessels is multifocal, it's picking off random segments of different peripheral nerves one by one.
So, left radial nerve 1 week, right? Common peroneal nerve a month later.
Yes. But Tracy highlights a major diagnostic trap here.
I wanted to ask about this because, so if a patient waits too long to see a doctor, a sniper attack on individual nerves suddenly looks like an area of effect carpet bombing.
That is exactly what happens.
How does a doctor ever figure out it was vasculitis then, if it just looks like standard symmetric diabetic style neuropathy?
It's tricky. This is why a detailed history is just, it's non-negotiable. You have to look for red flags. Like an upper limb predominance. Or non-length dependent features. Usually standard metabolic neuropathy starts in the toes and creeps up evenly.
But vasculitis doesn't.
Right, and you look for a stepwise progression in the history. Distinct temporal hits to different nerves over time.
Got it. And to prove it, they do a nerve biopsy, right? But the source says there's a really strict rule for that.
Oh, absolutely. A blind nerve biopsy is basically useless. The surgeon must select a clinically affected nerve.
Because if you picked a healthy nerve, you miss the evidence.
Exactly. You miss the inflamed blood vessel entirely. So you have to sample a nerve that is actually showing deficits, usually combined with a muscle biopsy.
Okay, so that covers how vasculitis damages the nerves locally. But we need to zoom out, right? Why is the body doing this?
Right. This is where the systemic clues come in. Because the nerve damage is often just a localized sign of a much bigger whole body problem.
Like severe weight loss, fevers, multi-organ stuff.
Exactly. Lung, kidney, GI tract involvement.
Which brings us to the alphabet soup of antibodies, the ANCAs.
Yes, the antineutrophil cytoplasmic autoantibodies.
Right. And the text specifically mentions two big ones, MPO-ANCA and PR3-ANCA.
Right, so MPO-ANCA targets myeloperoxidase, and that's strongly linked to microscopic polyangiitis, or MPA.
And PR3-ANCA targets proteinase 3, linked to granulomatosis with polyangiitis.
GPA, you've got it. These antibodies basically cause your own white blood cells to dump toxic enzymes directly onto the vessel walls.
That sounds brutal. And here's where it gets really interesting, tying back to the intro. Let's talk about case 4-1 from the text.
Ah, yes. The 42-year-old woman.
Right. So she develops this painful wrist and finger drop in her left arm over just 3 days. Then a month later, a right foot drop.
Classic mononeuritis multiplex progression.
Exactly. But the smoking gun for her foot drop was actually her adult onset asthma.
Right, because testing showed she had that MPO-ANCA we just talked about, plus eosinophilia, a high white blood cell count.
Which led to a diagnosis of eosinophilic granulomatosis with polyangiitis, EGPA.
Yes, and it perfectly shows why multidisciplinary care is crucial here.
Because the neuropathy is just the alarm bell ringing.
Exactly. The actual fire is a systemic rheumatologic emergency. If you don't treat the EGPA systemically, it's going to go after her heart or kidneys next.
Wow. But they treated her successfully, right? With steroids and rituximab?
They did. By hitting the immune system hard, they stopped the antibody production and stabilized the nerve damage.
Okay, so that's vasculitis choking off the blood supply. Let's pivot to a different category. Connective tissue diseases.
Right, this is a whole different ballgame.
Because here, the immune system isn't targeting blood vessels, but other structures that just kind of inadvertently wreck the nervous system.
Yes, Sjogren's syndrome is a great example of this.
Yeah, let's talk about Sjogren's. Most people, if they know it for severe dry eyes and dry mouth, right? The sickest symptoms.
Right, because it attacks moisture-producing glands. But between 5% and 20% of these patients actually get peripheral nervous system complications.
And the source says the most devastating one is sensory neuropathy.
Yeah, this is fascinating anatomically. The immune system targets the dorsal root ganglia, or the DRG.
That's where the cell bodies of the sensory nerves live, right?
Exactly. And unlike the nerve trunks in your arm or leg, the DRG doesn't have a strong blood-nerve barrier. Its capillaries are fenestrated.
Meaning they're kind of leaky.
Essentially, yes. So antibodies and inflammatory cells can just wander right in and attack the cell bodies.
And if you kill the cell body, the whole wire dies.
Instantly, which causes severe, large fiber sensory loss. Patients lose their proprioception, their sense of where their limbs are in space.
The sensory ataxia, plus absent reflexes.
Right. And the frustrating reality with Sjogren's neuropathy is that it generally doesn't respond well to immunotherapy.
Yeah, the paper cited a really specific study about this using rituximab.
Right. Rituximab only had a 90% response rate if the patient also had other specific features, like cryoglobulins or actual vasculitis.
Wow, 90%. But if they didn't have those overlapping features?
The response rate dropped to just 29%.
That is a massive difference. Just goes to show how complex diagnosing the exact mechanism is. Which brings us to rheumatoid arthritis, or RA.
Yes, another huge connective tissue disease.
The source noted something crazy here. Subclinical neuropathy is incredibly common in RA. Like one electrophysiologic study found it in 57.4% of patients.
Over half, yeah. They might not even feel numbness yet, but their nerves are already taking a hit from the chronic systemic inflammation.
But I want to stop and highlight this massive contradiction the text brings up regarding RA treatments.
The TNF alpha inhibitors.
Yes. So, wait, what does this all mean for the patient? The very drug designed to calm your immune system and save your joints, the TNF alpha inhibitor, can accidentally program your immune system to eat your nerve insulation.
It sounds totally contradictory, doesn't it?
It's the ultimate medical irony.
It really is. But this is where critical thinking in medicine is absolutely paramount. Tumor necrosis factor alpha, or TNF alpha, is complex. It drives joint inflammation, but it also helps regulate your immune system's peripheral tolerance.
Oh, so if you block it too hard.
You can inadvertently unmask other autoimmune responses. Suddenly, your T cells decide to attack your peripheral nerves, causing a demyelinating or axonal neuropathy.
So a neurologist seeing an RA patient with nerve pain has to figure out, wait, is this just structural damage from a deformed joint pinching a nerve?
Right, an entrapment neuropathy.
Or is it actual autoimmune axonal loss from the RA? Or is it drug-induced toxicity from their joint medication?
Exactly. You have to tease apart those three entirely different mechanisms, because the treatment for one might make the other one worse.
Man, that is incredibly difficult. Okay, so we've covered immune systems getting confused by vascular targets and connective tissue targets. Let's move to our final major segment, the hidden enemy.
Paraneoplastic neuropathies.
Right, because what if the immune system isn't confused at all? What if it's accurately fighting a deadly threat, but the nerves are just caught in the crossfire?
That's molecular mimicry in action. In paraneoplastic neuropathy, you get an acute to subacute onset of asymmetric nerve damage. But it's triggered by an underlying, often hidden cancer.
So the tumor makes a protein that looks exactly like a protein on your nerves.
Exactly. The immune system sees the tumor, mounts a massive attack, creates these highly specific antibodies to destroy it. But those antibodies also bind to your healthy nerves.
The text lists some key autoantibodies that act like fingerprints for this.
Right. There's anna-1, also known as anti-U.
And CRMP5, or anti-CV2.
And amphiphysin.
Yes. And if you find these antibodies, it is a massive red flag.
The text gives an example of a patient with severe autonomic issues. Like autonomic reflex screening showed postganglionic sympathetic pseudomotor dysfunction.
Basically, their automatic bodily functions were failing. Right. And orthostatic hypotension, feeling super dizzy when standing up. And a paraneoplastic panel revealed NNA1 antibodies because of a cancer history.
Exactly. The autonomic nerves were taking the hit from the cancer-fighting antibodies.
I just marvel at the detective work involved here. You come in feeling dizzy when you stand up and having numbness in one arm, and the neurologist tells you they need to scan you for a tumor?
It sounds like a leap, but if we connect this to the bigger picture, it makes perfect sense. The presence of these specific antibodies means the neuropathy is acting as an early warning radar for the cancer.
Wow, early warning radar.
Yeah, and because of that, treating the neuropathy often means you can't just give nerve meds. You have to hunt down and treat the underlying tumor.
Because if you don't remove the tumor, the immune system will just keep making the antibodies.
That's exactly right.
That is just incredible. Okay, let's summarize this journey we've been on. We started with sniper attacks on individual nerves and vasculitis.
The mononeuritis multiplex.
Right. Then we looked at the wild asthma connection in EGPA, the treatment paradoxes with TNF alpha inhibitors in rheumatoid arthritis.
And finally, the early warning cancer radar of paraneoplastic antibodies.
Yeah, and this is exactly why this matters to you, the listener. Chronic painful nerve issues aren't always just wear and tear or carpal tunnel.
Not at all.
They can be the immune system trying to tell us a much, much larger story about what's going wrong inside the body.
And before we wrap up, I want to leave everyone with a final lingering idea to mull over based on all that.
Oh, please do.
So we've just spent all this time learning that the immune system can produce incredibly specific homing beacons.
Like the NNA1 or MPO and CA antibodies.
Right. Antibodies that seek out and bind to exact microscopic targets on our nerve fibers or in the dorsal root ganglia.
Okay, yeah.
Well, if the immune system is capable of this pinpoint, target-seeking accuracy to cause damage, could future therapies eventually be engineered to use this exact same antibody homing mechanism?
Wait, like using the enemy's map?
Exactly. Could we use that mechanism to deliver nerve-repairing drugs or regenerative medicine directly to the dorsal root ganglia?
Oh, wow. So instead of a payload of toxic inflammation, the antibody delivers a payload of, like, healing factors?
Exactly. Using the disease's own targeting system as a cure.
That is absolutely mind-blowing. What a thought to end on. Thank you so much for joining us for this deep dive into the hidden world of axonal neuropathies. We hope it changed how you look at the nervous system. So until next time, keep asking questions and stay insanely curious.